It's a collaborative effort, and it has the potential for her to allow patients to be more actively involved in their health.
This would be one of the most important changes that we can ever make in healthcare.
What a rPHR required is a longitudinal record of all health information from birth and uploaded, like everything that from past is actually uploaded into the PHR. And that it needs to be system agnostic, you spoke about that, and interoperable. That we needed to take into consideration privacy and security and OCAP principles, which relate to our Indigenous peoples. And education, patients, and care providers, and it needs to be a multidisciplinary team, not a design team. So we need to make sure that everybody is around the table to take a systems thinking approach.
I did have a personal experience, and I won't take you long, but my mother was very ill. It was one of the reasons why I decided to be a board member. Was she just recently passed away of cancer. I quickly found out with all the multiple agencies I had to deal with, I had to manage her care. And it did exactly what you said. She would go to Vancouver, and we had to turn around and come home because the oncologist in Prince George had given her chemo treatment and didn't pass any of the information on. When I talked to Vancouver, they said, that's up to you to get us that information. So it's needed. So that's just a story on the side. This is long overdue, and I'm gonna fight real hard to make sure that this happens.
We had a scenario of a mom with multiple children, all sorts of things going on in her life. And so I was trying to think from the patient's perspective, what would we need? And we decided number one was that patients really need to appreciate that the systems don't talk to one another and that our expectations are unrealistic if we're going in and assuming all sorts of things are interconnected. Because if our patients didn't make that assumption, I think that they would be demanding that we make this a priority. So we felt that number one was making patients aware that it does not exist and we need your help to make it exist. And then the second part of it, and that will create pressure on decision makers. These are taxpayers and the people making the decision, like Shannon here, he didn't know until he had to experience it himself. We'd like people to understand before they experience it. That would facilitate decision makers in making this a higher priority. We also felt that along the way, users need to have some literacy and some understanding about their role in participating in their care, what patient-centered care means for them. And so that meant that they would have to appreciate that they need to be active in sharing information, active in contributing, active in using a portal, or an EMR. Ways for them to have advocates with them. If you're an older person and you're not comfortable, you would need to be able to have an advocate come with you or be in your portal with you, training for users, all of those kinds of things. So we took it more from our scenario's patient's perspective, assuming, maybe wrongly, that the technical bandwidth, the other things were already being discussed by those experts.
We have a vision that in a perfect world, or at very least in our healthcare system here in BC, that the patient, his or her family, be meaningfully included and integrated as a partner in their care. Partners in primary care networks, community team-based care, and care planning. You'll notice that front and center, of course, is the patient, the person, the citizen, his or her families, constantly front and center as they navigate the complex, complicated system and access services at different levels. We view them as the protagonists in that journey where they can learn about their health, manage their health, advocate for their health, and ultimately expect and hope for better health outcomes. So we're on a mission, of course, to support full citizen access to patient health information, to facilitate patient engagement and partnerships in health, which brings us to personal health records, also known as electronic personal health records. I'd be happy to talk to you till you're blue in the face, validating all the benefits to providers and MOAs and patients, of course, of having an integrated, holistic personal health record. But more than that, I want you to consider these words. Personal health records can be a game changer. It's one of the greatest opportunities we have to improve quality. And when we think about how we create a sustainable healthcare system that is high quality and built on the quadruple aim, the PHR is core to that, and I don't see us achieving that without a PHR in place.
Okay, so we're talking about defining a PHR. We are on a journey from portals to personal health records. We're not there yet, where we are is really trying to define what a patient health management system would look like for all of us in the future. So we're thinking a holistic, we're thinking an integrated and a portable platform for persons and their family and their caregivers to access their health and manage themselves. Right now in the current patient access that we have regional and provincial siloed portals in British Columbia, and many of them. What our future is toward a patient that has a full copy of all their health information they need to look after themselves in a holistic view of themselves. The experience we would like to see currently, patients can see their data and they have limited portability and you have to take it with them. They're often doing this manually. What we see in the future is that patients can interact and become an active member of their care team. Patients are being controlled to carry their information with them and tell their story as they move through our health system. And then the impact. Right now, the patients are sitting with their data and they have limited advice or support on the next steps or actions or the plans or what they should do next. What we envision is an empowered patient that can fully participate in their wellness and their health management. We're taking a vendor agnostic approach, which means we're just shameless, we'll work with anybody that'll work with us. And we're community driven, which is one of the reasons I got involved with RCCPC, the community up approach. So we work with the standard PHR products and advocate for the independent and support the development toward the future. And here's some things we pulled out, and we call them the critical secret sauce. So the first one was open standards. If these systems end up in proprietary, it really limits the portability of what you can do with the systems. So an open system and open standards is really important. And that was a failure point in several projects. Complete data sources. So talking about all the data sources accessible from inside the patient's PHR of choice. If they don't have a PHR, then they have their portals. So we're also talking about, this was a critical piece, integration. So not just a standalone system where the patient is facing a corner by themselves, but they're facing their care team and they're coalescing around the same information and wanting to be able to take care of themselves in the same way so they know what's next. So fully integrated was a key component. Access and portability. I'm from Smithers, BC. I'm a rural patient. We sometimes, transfer against several health authorities, so being portable is really important to us, and we have limited availability of internet in the north as well. And if you change providers and location, it's also very difficult if you have that, if you don't have the portability. And then the big one is the provider support needed. The projects that focused on all the above elements but didn't provide support for the providers as well to become part of the care team with their patients also had some challenges. So we need to champion the value of patient partnerships and we need to showcase the opportunities and support that change in workflow and address those concerns. So these are the elements that we advocate for. We're not there yet, we're at the beginning, but we're on our journey. We are vendor agnostic, we are community driven, and we are focusing on the critical elements.
We took a design thinking approach to our community engagement at Belmont, and it culminated in a one-day workshop where we coalesced at Belmont with patients, citizens, MOAs, and providers, and we're able to together appreciate each other's journey and then finally set some community priorities wrapped around the PHR, which included leveraging technology to be able to access, manage, and seamlessly share patient information. The experience validated for us that they wanted to maintain a single patient managed record. So instead of a portal soup having 10 different places, they wanted to coalesce their information in one spot. And then finally, that the PHR itself shouldn't just be a place where you can access information, but also should have the functionality to enhance communication between members of the care team. Now, we're pleased to know that we're transitioning to our innovation lab portion of the project, whereby members of the community, MOAs, providers, facilitated by the RCCPC, but with Northern Health and the actual PHR vendor itself, Bright Health, we're working together to iteratively design a holistic and integrated PHR that we hope in the years to come will serve the unique needs, dreams, and aspirations of Belmont.
Hi everyone. So it's my health, it's my responsibility and it's my job to say who has access to my information as patients. So I take my uncle last night, I talked to him actually, and his doctor passed away and he went to get his records and they won't give them to him. It's his records that he's had for 30 years with this physician and he's not allowed to have them. Why? It's him. So we started this pilot project, as Justin said, and we've had some really great partners. The partnerships are key because everybody brings in their little bits of information, and all together we put that together in a wonderful package. So you've got to have the partnerships. You've got to remember, like I said, everybody has their information and the knowledge and the experience that is going to help that patient. And we're all patients. Every single person on the planet is a patient, and you have the right to have your information. Northern Health Authority and Interior Health Authority, which is where we deal with, those two systems don't talk to each other ever. So I have a friend of mine who's going through cancer treatments. She goes down to Kamloops, has her stuff, she has her tests, but the doctor up in Belmont doesn't get any of the information. The doctor down in Kamloops doesn't get any of her information from Belmont. Well, that's ridiculous. How is anybody supposed to, plan her care without all of the information? If she had a personal health record, here's my information. Here's my information. It's a no-brainer. So finally, I wanted to just remind us that as patients, it's our responsibility and our right to have and manage our own health and our own records.
So when I first became involved in this project and looked at the vision of rPHR, I immediately thought of how helpful it would have been for an older gentleman I'd just seen in the seniors wellness clinic. He'd moved from Vancouver to the interior where he was unable to access a family doctor. He'd been in and out of hospital for the last 3 years with multiple medical issues, and neither he or his family were clear what the next steps were going to be. It took me over 2 hours that day to try and piece together his medical history using every access point I had to the system. And even with that, there were big gaps in the information, including recent discharge notes, medication lists, consults. It's terrifying to think of the potential for errors and harm in his every interaction with the medical system due to this fractured medical record. The family assumed that his whole healthcare team would have access to all his records wherever they went, and they were shocked that this was not the case. And having a PHR would have been an incredibly powerful tool, not only for the patient and his family, but also for all the healthcare providers, as Colleen mentioned. And there's so many situations like this, where as a provider, you know how much easier your job would be if you had an accurate medication list, the latest discharge summary or care plan. Patients and providers deal every day with the potential harm from the data disconnects that contribute to the missing results and duplication of tests, inaccurate records, and medication errors. And a PHR has the potential to minimize harm just by allowing patients more control and understanding of what's going on with their health. However, when I thought about the PHR project from as a rural family doc, which is where the pictures are from, my immediate reaction was fear. So fear of 300 extra messages in my inbox every day, worried patients, and frustrated office staff. And the early feedback from physicians as we started to explore this project in community has been consistent. Fear of extra workload, patient expectations of immediate answers because they're worried, privacy and security and concerns, and inappropriate bookings. So what I've come to appreciate with this project is the fact that it's not about a pre-made solution that's delivered to every community regardless of context or capacity. Instead, it's about exploring the concept of a PHR, looking at the potential challenges and benefits as they apply to each community, and then slowly building an individual PHR that works for both the providers and the patients. And as we said in Valemont, we keep bringing up the same stories, but hearing patients express the challenges and the fear and frustration they feel and the lack of control of this complex system. But on the other side, patients were really supportive when we sat down, and they listened to the providers talk about the time pressures and the overwhelming paperwork and the fear of adding anything to that precarious balance that everybody's running on. That common understanding was powerful. So this project is designed to go slow, and I think that's important. To start with a mutually acceptable option, such as online booking, which is already happening in lots of places across the province. And then look at the next options as they become available. So for example, one access point for lab and imaging instead of through portals, text reminders and recalls instead, so to free up your MOA time. a way for patients to upload their results, their blood pressure and sugars, instead of having to wait for their doc and bring in all their stuff. Or an easy way to check up with your palliative care patients that's secure and actually interacts with your EMR. So the project also, which is the other powerful part, is it recognizes supports are needed for this. Like changing workflow processes is hard and it requires increased capacity. It's not something that happens off the side of your desk. So supporting MOAs and physicians, along with technical supports, educating patients is all part of this. So it's a collaborative effort and it has the potential to allow patients to be more actively involved in their health, to make providers' jobs easier, safer, and ultimately improve the quality of health for patients.
So if you allow me to reflect a bit on what we've heard, you have seen that we have a vision. We are seeing something in the future. That vision is determined by patients like Holly. Like she says to us, this is my journey. This is my information. And I wish to have the best care. And if we are serious about patient-centered and community needs-driven approaches, then we should listen to people like Holly. We are on a march. We are walking together on a pathway to create a new reality on how we carry our information in terms of health. We have done a deep environmental scan, and as we discover in the places in the world where this did work and did not work, we know today 90%, more than 90% of places where this has been tried, it failed. The majority reason why it failed was providers. Very interesting. And so now we are building from the places in the world that it did work. For example, Oregon, Scotland, Belgium. And we have incorporated that into our doing. So what you heard from Bridget is a story that patients want everything. Providers want a lot of things, including standards, but they are hesitant about certain things. The funder and the vendors that also play in this field also have different needs and expectations, and risks and challenges. So from all of that, we have defined that there are between 7 to 9 uniform standards that needs to be in place to make this an effective process. And there needs to be enablers to allow us to make this thing work. Our government needs to recognize that there should be policies and regulations in place that will tell vendors, you need to follow these standards. We unfortunately cannot get it all at once. As Nicole said, we will have to be patient. We will have to be brave. We will not need to fear failure. If this doesn't work, it's okay. We are at a QI conference. The best that this province can throw at us. We should be brave enough to discover what works and not work. And if we can land at a place that when we start this, such as the place in Belmont where it currently starts, we know we can schedule. We know patients can see their information. It's a unilateral information. It is a portal style. We wish to change that, as Bridget said, into a bi-directional change, that a patient can input their blood pressure measures, that they can input their blood sugar numbers, that they can check their allergy list, that they can go to their pharmacist as part of the team, can you check my medications and the doses so that they are correct so that I can take that with me. And then we can begin to message each other. Those are the only 3 that we currently can do in the system. And then there are multiple others where we wish to do it vendor agnostic style. So if you allow us to dream on and you see the imagine that's on the slide, imagine if a patient in Fort St. James from the community, Tackler Landing or Tatchay, hundreds of miles outside of our community, carry their little passport on their mobile device and can come and seek their service first with their patient medical home and their private care provider, their family physician in Fort St. James, That information on that passport is on the desktop because that's the patient's home. That's what happens in Belmont currently. But the moment that patient flutters to Prince George for a medical referral or an appointment, the continuity of that care is being compromised. And we stand for longitudinal relational continuity. And this is what this passport will give the patient. If that provider, wherever they now seek their care, or flutter to visiting their extended family in Vancouver, and they see someone with a different vendor, they can have a comprehensive, seamless experience that ultimately is safe, that ultimately prevent adverse outcomes, and puts the patient in the place that we preach every single day, in the center, where the community needs that's driving that process. That's the story of what we are trying to accomplish. We each will find ourselves in different places along this journey. Where are you? What are you hearing from us? What does this mean for you? How can you help us be aware of the challenges that you think might be there and of the good that will come from this? That's what we entice you to be with us on this journey.
I just want to throw a little piece in there. We, as many, I'm a provider, and we've had an EMR in our system since 2004. In 2004, we asked the Ministry of Health and the BC government to make sure open standards were part of this, and they refused. So there's a whole history here that it's lovely that we're talking about it now, but here we are, I don't know, do math, 18 years later. Come on, that's all I can say.
I think one of the elephants in the room is security and privacy. And I think, I was just discussing is that when I go to my doctor's office, I don't know who the MOA is that has access to that. I don't know who they socialize with, who they might share that with, what's their confidentiality within their employment, because they're working for a doctor who's a private contractor to the healthcare system. So I already don't have control over my health records. I would actually have more control if I had it, because then it's my obligation to control my records. So I think this is a wonderful idea, it's long overdue. And I think the elephant in the room is the government's so afraid of security and privacy, which doesn't really exist anyways. It's a fallacy to a lot of things. And I think, I can look over a shoulder on a cell phone. People share things now that they wouldn't normally have shared 10 years ago. And I think this is going to take a long time to implement, which means generationally, the older people like myself are going to be gone by the time this is fully implemented. So the generations coming up behind us are already more comfortable. Kids at 3 and 4 using cell phones, they will demand this because they are used to that. They want instant access to everything. So it's going to take a while to get there, but I think it's going to be driven by us talking to our families and our friends and the younger generation specifically, because they haven't developed these acute chronic diseases necessarily, and they might see the advantage, but they have to see their parents dealing with this problem.
This would be one of the most important changes that we can ever make in healthcare. So the change curve says to you, the first phase is one of doubt, one of denial, and one of uncertainty, and it goes downhill. And during that phase, we ask the question, are we doing the right thing? We are even blaming ourselves and we are blaming others. We are using data to accomplish that judgment instead of the real quality that should be improved. And only when we reach the last low dip, then we get to the phase of acceptance. This work will be hard. You being with us on this journey, making sure that the patient has the right to carry their information at all times. And you know what? I heard a lot about privacy and security. You're all right. But what I have learned on my journey, if a patient tells me, this is my information, you might think you are the custodian of that. It is my information. We better begin to live the value of a patient-centered approach.
Personal health record requires it to be digital in its essence, but it also for rural and remote areas or complicated areas or seniors with dementia and things like that, there also needs to be a built-in what do you call it?
Analog.
Copy. Thank you. Analog process with it so that they can have a binder on their counter that they can put it in, and a son or a daughter can help them with and stuff like that. So I think we need to work on the digital part of it, but we also need to make sure that there's an analog component where that's appropriate for the patient.
I just wanted to share something that David had mentioned, and he said, you know, when we're talking about bandwidth, and yet some information is actually just faxed still, in between departments, and you know, not everybody has fax machines, so that's the leap that we're taking, is from faxing to broadband.
The fact that that's still we used to get calls in the rural town I was at from the A&W. I think the fax came to us from somewhere. Like, that's not secure.
I didn't even know faxes were still a thing. Sure.
We're all from Northern Health, and we were just actually talking about the technological piece and like what already exists out there that people can look to. So, you know, your credit report pulls from all different systems, right? There's interoperability, there's agnostic vendor side development. You know, you can go to a portal and you can see all that information coming up, but it's actually coming from all different kinds of places. So that technology exists and it's available. I think the complexity that we have to deal with when the gentleman over there said he wouldn't be around to see it implemented is how hard it is to implement technology in our already complex environments, and so looking to implementation standards as well for that. So
there are a lot of people who have information in their health record that they actually don't want everybody to see. And I can think about young teens who would absolutely, or young people who wouldn't want their parents to have access to their health record. And so there are all these other little bits of it where you go, like, what age do you allow that to be managed? Or even I have some elderly patients where one of their children will email me something and say, but don't tell so-and-so. And so I put that in the patient's record because I want it to be there, but I wouldn't ever want the elderly parent to know that this is what their child said to me. So I think that we really also have to be mindful about what parts of the record you want everyone to see, and then who has access to it.
As a patient who has used the health portal since 17 through Interior Health to manage my own health because I had no physician for 5 years, was refused by 2 physicians because I was too complex. The issue is proprietary systems. You've got to get rid of that because I'm giving it to the patient owns it. We cross all borders, all jurisdictions.
We talked a bit about the issue of the record's vital for providers to deliver the care. It's essential in what they're doing, and consensus among providers about what's in it and how it works is going to be really vital. And the broadest consensus you can achieve is as the most value in terms of just that continuity between as many different points of care as possible, but that consensus building is going to be pivotal.
So one of the things that came up when I was helping my mom navigate her care through her cancer was there was inaccuracies in the records, and trying to fix that is really challenging. And even knowing where to go, like I must have called 3 or 4 different agencies and nobody said they could help me. So there needs to be a wayfinding of like when something's wrong, like where do you go, who do you talk to, all that. And then the other piece, just to bounce off somebody's talking about technological literacy for patients, I was thinking that should start in elementary school. Like that should be part of your health literacy curriculum as a youngster, and then just bring them up into the system.
I am a patient partner, and yeah, this is my vision. This would be my wish. It's been on my bucket list, my Christmas wish list for a long time. I have a couple of clients and just love everything that's been going on here. And I think for me, something like this is really essential for my medical safety issue. 100% agree with that. And I think it really would support both my healthcare team as well as myself to be on board. I have medical binders this big. I have all my images on CD, let's say, which doesn't really help me on the healthcare team driven laptops and on the soul with CD drives. 2 comments. I'm hoping that privacy will not be a barrier to moving things forward like this, given, I think, was a gentleman's comment on the fact that a lot of people, privacy is no longer an issue in many avenues that we pursue these days. I think technology can help us move forward on that, but I think it should be addressed. But I hope it's not a barrier to move forward to prevent medical safety and error. Secondly, I think it would be interesting to look at this, and I so appreciate the work you're doing. I would love to see this type of concept looked at a pan-Canadian level, because I think that's one of the big concerns I have as a patient is how do we take this to a broader discussion, a bigger discussion. I'm on the Canadian Medical Association's Patient Voice Council, and it is something that we look at there is how do we take this to a federal level, because this is something that is not unique to me in BC, but also something very similar that happens in Ontario, something that happens in Quebec. How do we do that? How do we raise, and I love the comment here, is where we say, how do we make people aware that are not patients, that are not myself, that are regularly in the ED, that have this struggle, but it's only once you become a patient, when your loved one becomes a patient, that you realize the fragmentation of the system. But kudos to all this work, because I think it's amazing. And I just think you're so right, so thank you.
And in the future, when people are going to be displaced more and more and facing different crises, I think having that record will be even more necessary.
As patients, it's our responsibility and our right to have and manage our own health and our own records.
We better begin to live the value of a patient-centered approach.